Okay, welcome everyone to a special Thursday Night Live filmed here on a Friday today with the great Dr. Barry Gillespie. And if you are a member, you get to join this nice and early and exclusive. So before we dive in, I would love to take a moment to introduce Dr. Gillespie today. And Dr. Gillespie started out in 1975 as a conventional periodontist, and he turned to alternative methods after developing headaches that medication just wouldn't resolve. So his journey led him to craniosacral and myofascial work, where he discovered his passion for helping children and infants. He believes that soft tissue traumas at birth often are often the root cause of many health issues. And with over 1,000 case stories on his website, Dr. Gillespie advocates for the importance of craniosacral fascial work in improving airway health. Welcome, Dr. Gillespie. We are so happy to have you here today, and we are going to be talking about the missing piece in the airway world. So welcome.
Thank you very much for having here. I'm very appreciative of people interested in airway work. I've been in dentistry or been involved in dentistry for over 50 years, and I've been waiting for people to wake up to the airway. So I'm very, very happy. And I consider your group the cutting edge. You're the one percenters, the people who get it. So I always like to talk to those people because they would be probably the most likely interested in what I'm doing and seeing, how they can go to the next level.
Absolutely. I'm excited. I'd love to kind of dive in and start. Our topic today is the missing piece in the airway world. So I'd really love to know from your perspective, what is that missing piece and why do you think it is so crucial for overall health?
Yeah, craniosacral fascial therapy is really it's important because you're looking at a basically a missing piece of your work. If you just focus on the fascial web connects every cell of the body. There are about 40 trillion cells in the body. They're all connected together. And what happens is, if you remember in embryology, around day 14, that blastula, it invaginates and it creates the mesoderm, the ectoderm, and the endoderm. And that's where every cell of your body is formed. At the same time, on day 14, the fascial piece also originates. So every cell that's created in the embryonic stage and for the rest of your life is connected into this fascial web. So it's really, really critical. Nobody ever thinks of fascia or even as a full body web, but it's very important that it needs to be loose. And if there's trauma, and there could be birth trauma, fetal trauma, trauma during labor, trauma during delivery, trauma anytime in life, that creates restriction, creates tightness in this web. You can have a lot of conditions that develop from that, and we can talk about that later. So it's very, very important. I know most of you are into the myofunctional world, the speech therapy world, and we'll talk a lot about that. But I want to introduce you to the fact that maybe there might be issues in the lower respiratory system, in the trachea and the lungs, the tracheobronchial tree, all the way down to the air sacs, even into the diaphragm, which is a main breathing muscle. Hey, let's get that loose. Let's get that going. So there's a lot we need to talk about. And so I think I'm interested in this cranial sacral fascia. And the cranial sacral work is important because the brain needs to breathe and needs to slowly expand and needs to slowly contract for correct neurophysiology. And when the fascia gets tight, it can create strain within the cranial bones and twisting and tightness and restriction. And that can lead to a lot of conditions in and of itself. The connection between cranial sacral and fascia, myofascia, the fascial web, is a cerebrospinal fluid. There's some research study that was done that what the researchers found with electron microscopy is that the cerebrospinal fluid ended up in the tubule of the collagen fiber. They didn't know what to expect. So that was a connection between cranial sacral and the fascial web. So the fluid that end starts in the choroid plexus, goes through the ventricles, goes out through the spinal and cranial nerve sheaths, go into the fascial web, go into that collagen fiber. So it's this craniosacral fascial system that's really important. And what I developed is craniosacral fascial therapy to unravel or to unwind the tightness in this system.
It's incredible. And you had developed that about over 20 years ago now. Is that correct?
You're you're being nice. I'm 77. I started this. Well, let me tell you my story a little bit. I
I would love to
graduated.
hear that.
I went to college for 4 years, went to dental school for 4 years, loved surgery, loved periodontics. I said I'm going to be a periodontist. I went for 2 more years of periodontal surgery, and a lot of your people are hygienists, so you know what that world's like. In
Yeah.
1975, I graduated. I was a periodontist. I opened my practice in Hyannis, Massachusetts, and Nantucket. I was there every Wednesday. And I thought the life was good, everything was good, and I started developing headaches and sinus problems. They wouldn't go away. So I went to the medical people in my office building, and they did some testing, and they didn't know what the problem was. And they said, "Here, take these drugs, and you'll be okay." So I went home and I looked at the drugs, and I said, I'm not going to take these. I'm going to find out why I have a headache. And that led me into the alternative world, which was at that time chiropractor. There's a local chiropractor that did applied kinesiology. And at that time in 1970s, you didn't really go to a chiropractor, but I did. You're desperate, your head hurts, you don't care who helps you. And I walked in there and he said, "You have a cranial problem." And I said, "What's that?" And that's when my whole education started. And I took the 100-hour applied kinesiology training in Boston with Dr. Goodhart, who discovered it. And then I got interested in cranial osteopathy. I studied with Dr. Viola Fryman from California. She mentored me. She
Yeah.
was the premier cranial osteopath in the world. And I also, when I moved to Philadelphia in 1983, I met John Barnes, and he is the best person in the world for myofascia, for the fascial concept. So the people I studied with were the best. And what I decided, I realized that when I started this work, that the cranial sacral system and the the fascial web are very, very close. It's not like there's cranial sacral over here and there's myofascial over here. It looked like they were one. And then I discovered in 2004 that the cerebrospinal fluid actually went from the cranial sacral into the fascia. So it's a definite connection. The craniosacral fascial system is one system and it connects everything in the body. So that's a little bit about my history.
That's wonderful. Thank you so much for sharing that. And I'd love to kind of go over that craniosacral fascial system a little bit more if you can. I've heard you discuss the brain breathing in the past and how it relates. So if you could kind of give us a full overview of that system,
Sure.
that would be
Sure. The
wonderful.
most important thing is the brain cycle, how well the brain is breathing. The brain has to slowly expand and slowly contract. When it's not, we can have all kinds of issues, like the laundry list of long issues. You can have headaches, you can have cognitive problems, you can have focusing problems, you can't think well, you can't concentrate well. And you see this with the concussion people, you can have all kinds of issues, cranial issues, and then the fascia, when you put the dental aspect of it together, you can have problems with the tongue, problems with the TMJ, problems with the eyes, the sinuses, the ears, the neck, and the throat. We see all kinds of situations with those. And in the fascia, what we found was that the fascia is a full body web, and something unusual that you may not be aware of is a lot of times there's fascial strain from the lower part of the body down into the pelvic floor, down into the pelvis, into the low back, into the abdominal area, into the diaphragm. If there's fascial strain down there, it can pull all the way up into the throat, the jaw, the tongue, the TMJs, and the head and create the problem. So you may be doing myofunctional therapy In this area, or you may be doing speech therapy here, you're not looking, probably not looking at the fascial aspect of it, where there's fascial strain in the tissues. And you probably won't be looking at a pelvic problem where they may be having a reproductive problem or a pelvic floor problem. You might think that's a separate issue, but in my world, it's all one. That pelvic floor issue is pulling up into the throat, into the head and the neck. So you really have to look at the whole body.
That is such a great overview. And I'd love to kind of dive into that a little bit more and talking about that system and how it relates to our airway world and how we can marry those two and discover that earlier. What
Yeah.
are some things that we can be looking for?
Yeah, let me talk about how I got interested in it. And I think it was 1978. I started seeing children, and I thought this was the greatest thing I'd ever seen. And I thought, boy, if I can really dive into this a little bit, it may change pediatrics. And I was very excited about it. Again, this is 1978. Nobody really knew anything. And I was working on children, and they were getting better. Their headaches were getting better. And I said, wow, this is great, because I was doing TMJ work. And in 1980, a mother brought her boy in. Little Billy came in. He had headaches, he had sinus problems, he had earaches, and he had asthma. I said, okay, I'll treat him for the headaches, and we'll see what happens to the other things. So I started working on him, and after 5 visits, I said, how's Billy doing? And the mother said, well, his headaches are gone, and his sinus congestion is gone, and his earaches are gone, and his asthma is gone. So I'm
Wow.
sitting there. Remember, it's 1980. I'm a periodontist. This is a new world for me. And all of a sudden, these types of patients are coming in. So I could see the headaches. Yeah, the cranial, and we got the headaches and the earaches. Yeah, we got the cranial straightened down and the sinuses. Yeah, I worked the sinus bones. But the asthma, down here, I didn't study asthma in dental school or periodontal school. And I said, that was just luck. I don't know. That just happened, and it happened to be luck. Well, the next four patients came in with asthma, and after I worked on them, their asthma went away. So when you see 5 patients and you do whatever you're doing up in here, cranial and fascia work, something's happening, and you want to find out. So I did a deep dive. I got all the medical textbooks on asthma. I went into the medical, the hospital libraries, looked at all the journals, and I studied all the anatomy and physiology. And I'm trying to find it, what I didn't learn in school, trying to find out what's at the root of the problem. And basically in 1980, I believe I found that asthma, which is a breathing issue, the main breathing issue, is a disease of fascial tightness. The fascial web is tight in the diaphragm, the main breathing muscle. It's tight in either or both lungs, all the way down to the air sacs. It could be tight in the tracheobronchial tree, the tubes leading into the lungs. It can be tight in the trachea and in the throat. It can be tight in the nasopharynx, oropharynx, nasopharynx, into the sinuses and nose and this whole area. And you see restriction in there where this fascia should be loose and everything, the brain should be breathing, everything, the fascial web should be loose, everything should be nice. Children are very, very tight and the tissue is very restricted. Once it's restricted, it'll create a lot of breathing problems. So when we think about myofunctional therapy, that's great, but you need to look at what's below and what's the root of the problem. The root of the problem, I believe, is tight diaphragm, tight respiratory system, starting down into the lungs, tracheobronchial tree, and working all the way up. What is really interesting is what I found is that the newborns that we worked with, I was out in Lancaster from 2006 to 2012. Every Wednesday, we saw about 500 or 600 newborns. Those newborns had diaphragmatic problems. They had reflux, they had hiccups, and
Mhm.
sometimes the mother would say, well, yeah, they noticed they had hiccups, in utero. And everybody thought that was cute. And I'm thinking, well, there's fascial strain in the diaphragm. That's why the fetus is hiccuping. And you're almost certainly going to have some type of breathing problem down the road and when they're born. So I'm trying to get the pediatric and neonatal profession to look at this fascial web and this craniosacral fascial system. And what I'm basically trying to say to this group is you may be interested in myofunctional therapy and you may have children and adults, and that's great. They need the therapy. If you want to get to the root of the problem, I believe that you need to go back into the birth, into newborns and infants, and start working on them to prevent what you're seeing right now in children and adults. So if we can get them when they're very born, I mean, when they're young, the first day of life or the first few days of life, that fascia can release really, really well. Everything can open up and you can prevent a lot of conditions down the road. So that's just a thought. I'm just throwing it out there to everyone. I
I
know you're
love
on the
that.
cutting edge now, but if you're really be on the cutting edge, you'll be start looking at newborns and infants and seeing what their problems are and extrapolating them to what can happen in children and adults.
I love that. Thank you. I know you and your group are known as the Happy Baby People, so I think this is a perfect segue into that. Um, and it's so great hearing that. And I have heard you talk about, prevention and the dental aspect of that from this aspect too. So how did you end up going from being this periodontist, treating people with periodontal disease? And I know you ended up in that fascial system, but what really drew you to infants without any teeth?
I know that's well, I'll give you the overview on that. I started as a periodontist and I was interested in TMJ and I used to do in the 70s, I did the jaw appliances and I did all the TMJ, what you did then, but I did cranial work and I did fascia work and these people were getting better. And I was getting people from all over New England. They would come in, and I was the headache guy in New England. So that's how it started. And then they started bringing their children in with headaches, and then with asthma, earaches, and learning problems and ADHD. And those kids started getting better. And in 2003, I worked for the Family Hope Center. I was on the staff there. We saw a lot of the brain injured children. So I worked with the brain injured children for 16 years. And then I was out in Lancaster in 2006 to 2012. We saw all those babies, and that's where the infant work started. I realized that when saw an adult, the problem probably started with birth trauma, but nobody noticed when they were born. And they grew up and they had sinus problems in grade school, and they had headaches in high school, and they had all kinds of issues. And then they got older and things got tighter and they got married, had kids and had more stress. And now I got migraines and I get back, and it just magnified on itself. And basically the root of the problem is at birth. If we can get these infants and newborns cleared, that would be the ticket as far as I could see. And with the newborns, what we see, we're very effective with babies who have difficulty breastfeeding. They can't latch on, they can't suck or swallow, may have failure to thrive. We see the babies with reflux. Refluxes are a very common situation. We see a lot of babies with colic. Oh, that's fascial strain. We see babies with gas. That's fascial strain around the digestive organs. And we see babies are constipated. That's fascial strain around the intestines. And what's interesting, the pediatrician will say, "Oh, well, they're going to grow out of all this; they'll be fine." And I'm going, "Not really, because that fascial strain will go into childhood and adulthood. That reflux might turn into GERD. That's 40 million Americans have GERD, so I guess those people didn't grow out of it." And it's interesting when they talk about constipation. They might say, well, as long as you're breastfeeding, they can go 10 days without a bowel movement. And I'm mystified when I hear that every time. No, you need to go every day. And what's happened is there's a lot of fascial tightness in that whole abdominal cavity, might be creating colic and constipation. The peristalsis, the normal peristalsis can't function. That tube can't extract what's in it, and everything gets kind of stuck in there. And what we do is to release the fascia. So now the tube and the peristalsis returns, and everything starts moving again. So there's that's our bread and butter. But we also see babies who have torticollis and plagiocephaly. We have babies who have strabismus and stridor and laryngomalacia. We see babies with pyloric stenosis. We see babies with clubfoot. And also, I'm trying to think, in the more serious problems, Chiari malformation, we have babies with craniosynostosis, and we have babies with hydrocephalus. So those are pretty much what we do, and it's a wide range. It's a long way from periodontics and maybe a long way from you, the listener, are at, but that's and when somebody comes into your, office, with a myofunctional problem, the baby has a problem and they say they have hydrocephalus, and, you have to be aware of there's a definite connection between that and what you're seeing now in children and adults.
Sure. And I think that's great for us to kind of talk about that more and about the conditions across the lifespan. Um, I want to kind of go into more. You mentioned birth trauma a few times, and we're aware of birth trauma, but what are some of the things that we can be looking for when we are talking
Sure.
with parents in terms of that? And then what conditions respond well to your therapy? Well, I know we kind of went over that, but even more of what you can share about infants and then children as well.
Sure. Yeah, I look at three areas of birth trauma. The first area is a delivery, what happens in delivery. And hopefully it's a vaginal delivery. And if it isn't, it's if it's a C-section, and C-section has its own issues. But let's do vaginal. We'll talk about vaginal delivery. Was the cord wrapped around your throat? That's huge.
Yep,
If the
I was
cord's
one of
wrapped
those
around your
myself.
throat like this and you're born, that cord, and what happens now is that somebody will undo the cord and, baby's fine. What if you're blue? Well, okay, that means that the area is pretty tight and there's blue, and you have to breathe, and they're very concerned about breathing. Or what if you don't take your first breath right away? That, they whisk you off into, the nether world and get you breathing again. And after that, it's done, in their world. In my world, that cord has created fascial strain in the throat, and what you're going to end up with is probably speech problems and myofunctional problems. And because that fascia holds the strain of that trauma and it can hold it for a lifetime. So even though you might be 50 years old or 70 years old and you have throat problems, um, I'm looking at Bobby Kennedy now and he has throat strain. I know he has throat strain. I'd love to get into his throat, but that's what I'm saying. It can happen at birth. So we're interested in the cord. We're interested if you got stuck. If you got stuck in there, it'll create a lot of pressure in your head. And when you pop out, your brain isn't breathing. So that creates a brain cycle, second brain cycle. That creates a problem. Um, you can have shoulder dystocia where you get stuck and your shoulder gets stuck and they start pulling on it or they break your collarbone. There's a lot of trauma in that. There's a lot of trauma during labor. If you have a long labor, it's a hard labor, and the mother has back labor. There's a lot of strain in there. It's a lot of strain on mom, and mom says, "Oh, back." Well, my mom gets an epidural, but what do you do for the fetal? What do you do for the fetus? That fetus has to suck it up, and that menstrual system's going to get really, really tight. So that's another tightness issue. The biggest problem we see is in fetal, in utero. If you're if you're not moving, if you're stuck in a certain position and you're twisted and your body's twisted like this, and you stay in that position for maybe hours, days, weeks, or even a few months, that is what you're comfortable with. And that's fine as long as you're in utero for those 40 weeks. But when you pop out and you have to live, you can end up with torticollis, plagiocephaly, and all the other problems that there's this fascial strain the fascia has developed. It's developed into this position. So virtually, every baby is tight somewhere and they need to be loosened up. And that's what I'm recommending.
Love
And for
that.
the people who, are non-scientific, the moms is, your baby's tight. And my nickname is Dr. Loose. People come in and I'm Dr. Loose and I will loosen your body, your baby. That's what we do. Happy babies are loose babies. Tight babies are not happy babies. They're fussy. They have trouble breastfeeding, they have colic, reflux, gas, indigestion, constipation, and they're fussy. And the medical profession has no answer. Well, they do, they have medication, but we don't want to do the medication. We want to get to the root of the problem. The root of the problem is birth trauma, where the fascia has been strained, and we need to work that through.
Absolutely. Absolutely. I love that. And am a huge advocate for that myself. Um, And so I'd love to know for those when they aren't able to be treated at birth, when we are beyond infancy, when we're starting to talk about children and adults, and these conditions develop into, worse and worse symptoms at times. When people start having your work done or the Gillespie approach work done, for someone who, let's say they're 50 years old and they have that birth trauma from an umbilical cord, how well do adults respond to this type of
Adults
work as well?
respond really well. It may take more visits. And literally what happens when you get into that area, you'll see a red ring right in the area where the cord was wrapped. All of a sudden you're working the head, you're working back here, you're working in this area, and you don't even touch the throat. And after you're done, you see this red ring where the cord, it's like a soft tissue fascial scar where the cord was, and it gets bright red. And I show the patients, and if you're a teenager, you're really cool. You take a picture of it, you put it on the internet, and send it to your friends. The 50-year-old won't do that. They'll go, "Oh, okay, wow, that's interesting." But that's what you see. We've seen it over and over again, and we have maybe a dozen on my website where we show the cord, and that's the fascia holds the memory of all the trauma. That's the problem. You can have birth trauma, that fetal trauma you're not even aware of, or something that happened when you were born, and it's with you your whole life, and it's creating problems that nobody will ever find unless you go retrace it, and you have to go back and to heal it. And that's what authentic healing is: go back into the root of the problem, have the body heal it to mitigate all the symptoms.
Wow, that is just incredible. And I feel like so many people can benefit. Again, just to kind of share my own thing, I was born with the umbilical cord around my neck. I've had the Gillespie approach done, and it was really eye-opening to how much of the systems are connected. So I love hearing that.
Thank you.
Thank you so much for sharing that. I would love to kind of talk about in our airway world, we see a lot of people with oral ties. And so I'm hearing you talk about a lot of fascial strains and tightness. So I'd really love to hear, because I know you've even talked about it contributing to trauma with releases. So what are your thoughts on oral ties?
Well, I have a lot of thoughts that some people might not want to hear, but I'll give you my thoughts. And this is just my opinion. As a periodontist, I saw babies in the 70s. I saw a number of babies, and I did oral ties at that time. And, from what I know now, and I look back on it, I said, gee, I shouldn't have done those. I wish I hadn't done those, but that's all I knew at the time, and that's all I was taught. So let me give you my spin. If you look at the oral ties, they're part of the fascial web. They're a small part, but they can be a really, really important part. And I'm kind of concerned myself with the lip tie, because I hear a lot of, I know there's oral ties up in the maxillary bone. Let's talk about the tongue tie. What I'd recommend, if a mother comes in, well, let me take a step back. Ultimately, you want to do this work on day one, get the baby strain free on day one in the hospital, or if you're home birth, at the first or second day. If there's still a problem with breastfeeding and there's a true oral tie, which will not release in this fascia work, then you need a frenectomy, or you probably need surgery. I'm on board with that. That's rarely done. So what I'm seeing is, a 5-month-old, they come in and they're recommending, the tongue tie surgery, the frenectomy. And I'm going, okay, maybe your baby needs it, maybe your baby doesn't. Why don't we just get your baby strain free and see if there's still a problem after all the fascia is released, then you can go do it. So that's what I'm trying to get people to buy into. Unfortunately, dentists aren't really aware of brain motion, craniosacral work, or fascia work at all. It's, for 40 years, I've been in King of Prussia, Pennsylvania, and I had really no dentist, no pediatric dentist. In the last couple of years, I've had Dr. Joanna Walska in Newtown, Pennsylvania, She took our training. She brought her little ones into me. She's fully on board. I send all my patients to her. So I'm fortunate to have a dentist orthodontist who believes in brain motion and fascia and tongue ties. So that's
Oh,
just
that's
my
incredible.
opinion before you click me off.
No, no, I actually, can I say too, I think that's so important because you're right. That's the fascial system. And if oral ties are part of the fascial system and part of the whole body, shouldn't we look at the whole body first and address the whole body first before we go changing the fascial system?
Right, right. And if you go do the tongue tie first, well, you've just treated the tip of the iceberg, and now you've got the whole body, the whole iceberg down below, and all that's pulling, and it can pull right up into the tongue. And just for the myofunctional therapist, there is fascia in the tongue. The fascia
Mhm.
in the tongue needs to be released. I mean, you're pushing a button. I'm pushing a button on myself here, but you need to look at the fascia. Remember, the tongue is a muscle. Around every muscle cell is a thin layer of fascia. So when the tongue is tight, which I see in a number of children, it's going to be hard to do myofunctional work on them. It's going to be hard for them to swallow and speak. The fascia in their tongue needs to be released. So I just wanted to throw that in there.
Oh, I love that. Thank you. And I again, I have some personal experience with this, but not everyone has been fortunate enough. So when you are treating someone who may have an oral restriction, what do you recommend in terms of, obviously let's get them to someone who is well trained in the Gillespie approach and let's treat their fascial system. What do you think is a good protocol for kind of checking in on that? Is it the fascial system or is there a true tie there?
I would work the fascial system and especially the oral structures and the throat structures. And when you get pretty loose, then you check to see how they can swallow. And then you go and you say, well, it's a true tongue tie now, and they really need to have surgery, and we need to go to the dentist to have some laser work done. That's how I see it.
I love
I'm not against surgery. I was a surgeon. I know the world. I'm not against it, but when I was a surgeon, the first thing we were taught was to do the most conservative first, do everything most conservative, and then surgery is your last resort. I'm seeing too many babies now. Surgery is the first resort, and okay, then oh, I'm sorry, your surgery didn't correct the reflux, didn't correct the colic, it didn't correct the breastfeeding. There's so many babies that I see that they can't latch well. The reason why they can't latch well is they can't open wide. Why? Because they have fascial strain all through their TMJs, especially the left TMJ. So you go into their lateral pterygoid muscles on either side and they're screaming. There's a lot of strain in there. They can't open their mouth wide. If they can't open their mouth wide, then the nipple can't get all the way back into the soft palate, and then they have a shallow latch. They're bobbing on and off all the time. So it's critical. And that's, I don't know how many babies that I've seen that have had the surgery and nobody looked at fascial strain here. And that's why their breastfeeding is not well. It wasn't because of the fascial, the tongue tie. That's just my opinion.
I appreciate that and I love that so much to hear kind of it's important for us to hear different opinions because it helps us open our minds that there's more than just one
Yeah.
thing that may be going on. So I appreciate that so
Yeah.
much. And
Can
kind
I
of
talk about orthodontics for a little bit?
you are like we're right on the same page. That was my next question was talking about, I've heard you say this before, orthodontic treatment and appliance therapy. I've heard you say it can create restrictions. So I would really love to hear more about
Right.
potential red flags and everything in that too. Yes,
So
please.
if you've been kind enough, I'm talking to the viewers, if you're kind enough to listen so far, if you can hold on for another 10 minutes, that would be great. Let me tell you about my world in orthodontics. My father was an orthodontist. I had a headgear. I had
Oh,
eyes extracted. I had everything that I looked at now. I like, oh my God, but this is the 50s and my father didn't know and nobody knew. So you have to work your way out of that. And when I was having work done, I had a lot of cranial restriction from orthodontics, and that's just the way it is. And I thought, what happened I'll give you a case in 1978. I worked on a young child and he had headaches, and his mother was so happy. After 5 or 6 visits, the headaches were gone. And he left the office. I didn't hear from him for about a year. And then the mother calls up and said, his headaches are back. I said, okay, well, let me take a look at him, see what's going on. What happened is we went to the orthodontist. The orthodontist banded him up, put an arch wire over here, tightened everything up, and it restricted his brain motion down to zero. It just tightened his whole head. And he was developing headaches from that. So, okay, so this is 1978. I'm a periodontist. I need dental and medical referrals. I need people on board with me. And I have to tell this orthodontist that he was the problem. He's the reason. I have to tell the mother and tell the orthodontist who's going to go to the orthodontist. This isn't good. This is not going to work out. It, it was a bad equation. And what happened, that happened a number of times. So there was problems in Massachusetts. So I had to leave that practice. I had another practice in Windsor, Pennsylvania. I had to leave that practice because I was having, these people were getting better and I was way ahead of my time. And I ended up in King of Prussia in 1983. But what happened was when an orthodontist puts an appliance or does any type of work on the upper jaw, the maxillary bones have this normal expansion and contraction. The maxillary bones have to breathe. They have to breathe with the brain. They have to expand and then contract. If you're putting an appliance in to widen the palate, that can restrict that brain motion. If you're putting arch wires in here with vans and tightening everything and moving teeth around, that will restrict the maxillary bones and brain motion. If you're putting in a retainer in after you're done orthodontics, snapping it up into the upper jaw, that can restrict brain motion. So it's not that I have difficulty with orthodontics. I live in a different world. I live in this craniosacral fascial world of brain motion. And mothers will say, well, we spent $8,000 or 10, I know you spent money, but what's more important, your child's brain or their teeth? And if it's their brain, they want the brain breathing, they want them to do well in school. And that's how it works. So basically my therapy is incompatible with conventional orthodontics. And that's why if you're in Philadelphia or in this area and you come in with an orthodontist, I'm fine. I know this is the standard of care. But if you're interested in really having a healthy child, you'll see, Dr. Joanna and we'll work together on that case. If not, that's fine. You can do whatever you want. So I don't tell parents what to do. I don't tell children what to do. And really, I don't tell dentists what to do. I left dentistry in 1997 after, when I was 50 years old to do this full time. So, I went to massage school. So I know this whole routine. So I've been down the road.
Oh, Dr. Gillespie, I love that journey there too. That's incredible. And dentistry, I love dentistry. I'm no longer practicing in dentistry either. I'm a retired dental hygienist, but I think there's just so much more out there. The more we know, the better we do. And one of the things you reminded me in ortho that you talked about the removable retainers, but what about those fixed maxillary lingual retainers too? Those I'm sure can create some hefty
Yeah.
strains.
Yeah, they can create. And what you really want to do, this is ultimately down the road and what Joanna does. And what I see in the future is that, when you're at the orthodontist, someone in that orthodontic office has to check for brain motion to make sure that when that child leaves, the brain's moving really, really well. Like when they come in, everything is fine. You don't want them to leave with a headache or, they start to have they have trouble in school. They're cognitive, they can't think, they can't focus, they can't concentrate. And everybody says, well, they're hormones and they're 12 or 13, and that's just the way it is. I'm saying probably not. The orthodontist is probably taken to a zero cycle, and now they have breathing problems, they have asthma, so when you're doing myofunctional work, you want to work with a dentist who believes in brain motion, who believes in fascia, who believes in the big picture, and that's what I believe in. So I've had the story since the 70 for 50 years. I've had the same story. It's the same in 50 years and now it'll be the same story. The brain has to
Right.
breathe, the fascia has to be loose, and then you do your dentistry around it, your myofunctional work, your speech therapy. How many kids have speech therapy because they have fascial strain in their throat? And you go back into the history and say, oh yeah, they had stridor, they had laryngomalacia, or they had a weak cry, and this is what we see in the infants. They had throat problems. They couldn't swallow. They had failure to thrive. They couldn't suck, swallow, and breathe well, as an infant. Those people you're going to have to ask the mothers, tell me about birth. Tell me about what happened. Tell me about what happened. What was the baby like? And what were the baby conditions that this child had? So you want to go back into the history to see where the root of the problem is. And for most of these kids, that's what you're going to see.
I couldn't agree more. I think that's why it's so important when we are doing these intakes on our patients, all of us, no matter which area in this, this profession, this world that we're in, that we're asking those questions, because the more people that ask them, the more of us that know, the better we are treating them. I want to go back to the orthodontic treatment just for a moment. With you and Dr. Joanna, what does orthodontic treatment look like between the two of you in terms of that? Because obviously you're still having people go through orthodontic treatment, but in a way that the brain is having its cycle of 200 seconds. So I'd love to hear a little bit more about that.
Yeah, what in a perfect world? Okay, we're living in a perfect world.
Right.
The
Not
perfect
always
world
realistic, but
is that I see the child or the infant or whatever. I see that child, and we get them strain free. Their brain cycles around 200 seconds. The brain's expanding 100 seconds or contracting 100 seconds. All the oral, facial, head, cranial, throat, I mean, the whole body is very, very loose. And I say, okay, it's time for orthodontist. Go to Joanna. She will look at the child in the case, and she might, I don't know if you're familiar with ALF, alternative light wire function. I mean, the orthodontists are big on that. They're removable appliances. There's a certain way you can do orthodontics without taking that brain cycle down to zero, without restricting it. So then that's how it looks like. And when Joanna's done with the dentistry, the child might come back to me just to make sure the brain cycle's good and the fascia's good. And that is a perfect world where now you have a child who's completed orthodontics. The teeth are in a nice place. The brain's breathing nicely. The fascia's very loose. Everything's working. The tongue's working. I mean, that's what I see for not just a few people, a handful of people now. That's what I see for every child down the road. Get the work done at birth. Oh, I have one more story to tell.
I'd love to hear it. I love hearing stories.
Yeah, I remember I was a periodontist. I was a dentist, and I was out there in Lancaster, and we had all these babies, and there was one baby that came in, and there were 85% of them were Amish babies, there were Mennonite babies, and they loved natural work. And so I was working on one baby, a newborn, and I had two of my colleagues there, and what I noticed was the palate was like this. The palate was like V-shaped. And I said, this the baby's a couple weeks old. The baby has a V-shaped palate. So I said, okay, let's do therapy. And we did therapy, and like 10 minutes later, we're done therapy. We did a lot of sessions in 10 minutes or 15 minutes. I went back and said, let me check the palate again. And I put my finger up into the roof of the mouth, and that V was gone. And that V became a U, where I could take my finger and go laterally, and that whole palate, the whole maxillary palatine bone, just expanded right out. This
Wow.
baby's a few weeks old. And I saw this multiple times with our babies. And I'm saying this is the potential for infants. We're seeing it out here in the Amish community. This is a microcosm of the universe, of what's happening in the world. And I'm seeing it happen in hundreds and hundreds of babies. It's going to happen worldwide. It's going to happen in America, and then it'll happen worldwide. And then I'm thinking, my God, orthodontics, if you're really sharp in orthodontics, you'll start to widen the palate. If you're not, you just go with it as is. But what they're going to find out, if this work is done at birth, that those V-shaped palates, those narrow palates, are going to become normal palates from the birth. And what I'm suggesting is, for the dentists and myofunctional people and speech therapists, if you see a child with a narrow palate, that child should have been seen when he or she was born, or at least in the first few weeks of life, to mitigate that. And they probably wouldn't even be in your office right now. So that's what I'm saying. That's where the profession's going to go. You might think you're a myofunctional therapist or a speech therapist seeing children and young adults and adults. What I'm saying is the future is infants, newborns, get them as close to birth as possible, check them out, get them strain free, open this whole area up. follow them for 8 or 10 years, see what happens to them, and everything's going to change. That's
Setting them
just
up for success,
that's just my
right?
world.
I
I,
love that. I think that is why this work is so critical at birth, right? Because it sets the stage for the rest of your life.
yeah, I
Um,
mean, I was working on people with headaches in the 70s, and then when a child came in, I said, well, this is a lot easier, working on children. And then you start working on newborns, and you start to connect the dots, and you say, hey, they're having the problem at birth. The fascial strain, the trauma, the birth trauma is creating the problem in childhood, in infancy, and in childhood and in adulthood, and nobody's looking at it. The sooner you can
yeah,
get at it, it's like an injury. It's like the 24 hour. You want to get the first hours. You want to correct as much as possible at birth. You want to mitigate as much strain while the injuries, the soft tissue injuries, are all fresh. You don't wait until you're 50. You want to wait until you're 77. You don't wait until you're 5. You want to get it done as soon as possible. And where it's
yeah.
easy, there's no drama. You're just been born. The fascia release easily. Everything opens up nicely, and the mother leaves the hospital with a happy baby. You have a baby who can breathe well, they can nurse well, they can digest well, they can poop well, they can nap well. That's my world. You leave the hospital with that, you're going to be a happy parent. You're going to be a happy mother,
Happy,
happy,
happy babies. I
happy
love that.
babies, happy
Yeah,
families. That's what I see out there. I see this work being done at birth.
that's incredible. Now I know we don't have much time, but I just wanted to touch on this since we are talking so much about infancy. You have done a lot of research with infants, is that right? And I've heard you
Yeah, we
talk
did.
about
Yeah, we saw.
body or the brain score and TMJ in infants. So
Yeah, we saw
that
TMJ in infants, and the big thing about TMJ is the latching issues. They can't open their mouth wide. They have TMJ. So in the 70s, I was the TMJ guy, and then 40 years later, I found out, wow, TMJ starts at birth trauma. I didn't realize that, and nobody realizes that in dentistry. And I started telling my periodontist, some of my dental friends, and they could care less, that doesn't affect me. But in the real world, that's where it's going to happen. You have TMJ at birth. And that's when an adult comes in or a child comes in with TMJ, we're going to have to take your fascial web, your fascia is remembering all that birth trauma. We're going to have to release all that strain back into that birth trauma to clear that for authentic healing. And that's what you need for authentic healing, in my opinion.
incredible, incredible. This work is just so important.
It
I
is, and I'm very biased toward it, and I hope people have stayed on it. And if you if you want to click off, you can. But I do have the website gillespieapproach.com. You can go on the website. There's 1,000 stories there. We have it indexed. It's my web guy said it's probably the largest natural website in the world. There are over 300,000 words on it. I've spent about 12 or 13 years writing stories for that website. I wrote 3 books before, but in 2010, 2011, I said, I'm gonna write stories for the internet for the world because the world needs to see this. They need to read about it, and they can do it for free. All you need is a computer. You
incredible.
can do it for free. So.
Wow, incredible. Thank you so much. I can tell just by the comments we've had here
Can I just
that people
mention
are,
about my trainers?
yes, please do. Yes. Where can we learn how to do this work? Where can we learn more, Dr. Gillespie? I'd love for you to share that with
Yeah,
us.
just as a final note, you can go to craniosacralfascialtherapy.com,
Great.
craniosacralfascialtherapy.com, and you're going to see Kim Sherlock and Holly Steflik, my 2 trainers. They're excellent people. I love them both. They give a 3-day training and for adults and children. And if you're interested in newborns and infants, they give a successive 3-day training for newborns and infants. So if you go, you'll see all about the training. You'll see where the classes, the training are scheduled. They're all across America this year. You'd have to hop on there. You can register there. You can go on my website. You can check everything out. They're excellent teachers. The great thing about the class is you can walk in and 6 days later, you'll be able to work on adults, children, newborns, and infants. There's
That's
no
incredible.
advanced training. You learn it all in 6 days. If you just want adults and children, you can go for 3 days, but most people go for the babies. They want to get the work done, as soon as possible. They want to expand their practice into newborns and infants. So they take the whole 6 days. So I just want to
That's
put a shout out for them. They're terrific women. They do a great job in teaching, and I love them to death.
Oh, that's wonderful. Thank you so much for sharing that, Dr. Gillespie. And thank you for joining us today. This has been just a wonderful learning experience for all of us here. And we really appreciate you taking the time with us today. Any final words before we wrap up and I make our announcements?
Not really, but the brain has to breathe. Your fascial web has to be loose. That's what I'm saying. And I'd love to come back if you'd like me to come back. I could do another session, later on if people are
Oh,
really
Dr.
interested.
Gillespie, we would absolutely love that. And we will definitely reach out to you to get something scheduled with you. That's wonderful. Yes, the brain needs to breathe. That Dr. Gillespie, also known as Dr. Luce. Thank you so much for joining us today. And
Okay.
everyone in the session is really enjoying it. The chat, everyone has said thank you so much and that they've really loved
Okay.
this session. So we
Thanks.
really appreciate you joining us. Before we say goodbye today, I am just going to make a couple of announcements. So for our members, make sure that you keep an eye out for our weekend newsletters, and we will announce our upcoming guest speakers and special announcements. We do have coming up this April, let me get the dates here, April 10th through the 12th. We are going to be in our Airway Circle retreat, and you can get that information by going to www.airwaycircle.com/retreat dash 2025. And we are going to have the wonderful Dr. Kakwa with us there. And then we also have both of our Foundations of Orofacial Myofunctional Therapy waitlist and our MyoCircle waitlist up. And our foundations course, which is our intro course, begins this August 2025. And our MyoCircle, our advanced training course, begins in January 1st. So you can head to our website, airwaycircle.com, to find those waitlists. Again, thank you so much, Dr. Gillespie. It has been such a pleasure talking with you for the hour. And I really look forward to us talking more.
Okay.
And
Well,
thank you
thank you very
again.
much for having me. I'm looking forward to coming back again.
Yes, thank you so much. Take
Okay.
care.
Bye-bye.
Bye.